Hello today, my name is Evan Yu. I'm a professor at the University of Washington and member at the Fred Hutchinson Cancer Research Center. I'm a genital urinary medical oncologist, and my specialty is prostate cancer and bladder cancer. So today we have a very interesting case of a 66-year-old gentleman who unfortunately develops metastatic castration-resistant prostate cancer. His initial presentation was that he developed some difficulty walking and sleeping on his back due to some lower back and hip discomfort. His past medical history included hypertension that was medically controlled, no known family history of cancer, and he went to see his primary care physician who, given the pain and having never been screened before for prostate cancer, he did think about that on the differential diagnosis. He performed a digital rectal exam that showed a nodular prostate, and so he referred him to a urologist that went ahead and found on a prostate needle biopsy that he had stage T2, N0, M0 adenocarcinoma of the prostate. This was grade group 4. And of course, this is a high risk disease, but still has an excellent prognosis, certainly more than 5 years. Because of the excitement with germline testing, and it's been now shown to be about 12% in those with metastatic prostate cancer, maybe in the 3 to 7% range for those with high-risk localized disease, this patient did undergo germline testing that included multiple genes such as MLH1, MSH2, MSH6, PMS2, BRCA1 and 2, ATM, PALB2, and CHEK2. But this was unremarkable testing. He did undergo staging studies with a chest, abdomen, pelvic CT scan that showed no evidence of distant metastases or lymph node involvement, and his bone scan was unremarkable. However, of note, his PSA was 26, and he clearly, by grade group and PSA, had high-risk localized disease. Multiple treatment options were discussed to the patient, including radical prostatectomy and radiation as well, and he decided to embark upon radiation therapy. He underwent 8 weeks of external beam radiation therapy and neoadjuvant, concurrent, and adjuvant androgen deprivation therapy for 2 years. His PSA went undetectable during the time he was undergoing treatment, but then after he stopped androgen deprivation therapy, surprisingly 6 months later, his testosterone had recovered and his PSA had gone up to 5.9. It was felt that it should be observed for a period of time, and at 12 months, his PSA was found to be 16. He underwent some restaging scans at that period of time, and it was shown that he actually had some metastases on bone scan, that included the right femur and the pelvis. At that point in time, he went on combined androgen deprivation therapy with an LHRH agonist and also with abiraterone acetate. He had a period of nice response with the PSA that went undetectable for approximately a year before his PSA began to rise again rather aggressively. And surprisingly, at this point in time, he began to develop some pain. This pain was mostly in the right femur, where he had known bone metastases before. He was not requiring any narcotic pain medications, but he was using intermittent Tylenol and ibuprofen. At this point in time, the abiraterone was ceased, but the LHRH agonist therapy was continued, and treatment with radium-223 dichloride was initiated. He did receive 6 infusions successfully, and treatment was well tolerated at post-infusion follow-up.